Hello everyone, good afternoon. Let's enjoy the chest radiographs with Dr. Y. I'm Dr. Y, chest radiologist working as a medical professor in Korea. Today's topic is pulmonary hilum, session 11. Before starting the new session of pulmonary hilum, let's review the previous session 10. About pneumonia, lobar anatomy. What do we see? Where is the lobe involved by pneumonia? You got it? Yes, minor fissure, obliteration of the right heart border. Yes, correct. Right middle lobe pneumonia. Where is the pneumonia? Which lobe of the left? Diffuse haziness, airspace consolidation, and air bronchogram from the top to the bottom. But if you see carefully, CP angle area is preserved, diaphragm is preserved, aorta line is preserved, heart is obliterated, Luftzeichen sign is visualized. So this is left upper lobe lobar pneumonia. Correct. Now you are the master of the lobar anatomy of the lung. Let's start our new session, pulmonary hilum. Hilum is actually a broad area, not a point. This is hilum. Hila area, in fact area. Hila area. But we call this as hilum. This is superior pulmonary vein of right side, descending pulmonary artery of right side. This is hilar angle. It should be more than 90 degrees. And this is the hilar point. Left side of a pulmonary artery and superior pulmonary vein. This is the pulmonary hilum. Pulmonary hilum. Anatomy. Hilum is a generic term that describes indentation and surface of the organ, where vessels and nerves connect with the organ. It is the site on medial aspect of the lung where vessels and bronchi enter and leave the lung. Radiographs and CT scans. Hilum appears as a composite opacity at root of each lung produced by bronchi, arteries, veins, lymph nodes, nerves, and other tissue. Fleischner Society. Hilum is singular, hyla is plural, and hyla is an adjective. These words were coined by Dr. Benjamin Fersen. Components of the hilum. First, bronchi. There are not a single bronchus on the hilum. For example, on the right side, right main bronchus, upper lobar bronchus, and the bronchus intermedius. So many bronchi are there. And second, the pulmonary arteries. All central pulmonary arteries are included here, so they compose the main density of the hilum. And also they are filled with blood. That makes the hilar density dense. And third, pulmonary veins. Superior pulmonary vein only. Inferior pulmonary veins are not included in the hilum. So their contribution in the pulmonary hilar density is less than pulmonary arteries and lymph nodes and soft tissue, etc. Why hilum so important? Because sometimes there is an unnoticeable pathology in the hilum. The reason why? Number one is hilum is crowded area with many bronchi, pulmonary, central pulmonary arteries, and superior pulmonary vein. And many anatomic structure organs means many diseases, mostly from bronchi. And the third, hilum is often overlooked, easy to miss something such as cancer. And hilum as important is perception. When you feel something strange feeling at the hilum, then we should focus on the hilum once again. And to 5, mixed lung cancer. Hilum is the #1 place of mixed lung cancer. We all remember this man, this healthy young man's frontal chest radiograph all through the sessions from the first session, right? Yes, this is normal coronal contrast-enhanced chest CT. Let's match these two films. We know this name, this name, this name, and this name. Can we match here, here, and here? Normally, left hilum is higher than right hilum. Why? Because left pulmonary artery is higher than right pulmonary artery. This is important. Increased hilar density. First, hilar region itself. Second, in front and behind of the hilar lesions, actually lungs. Written by Dr. Benjamin Ferguson. Let's start the real pathology in the hilum on the chest radiographs. This is the first case. Let's remember once again the normal, healthy young man's hilar anatomy. Let's presume left side of hilum is okay with this woman. What's wrong with the right side hilum? Please look slowly, deeply, thoroughly. What's wrong? You got something? Okay, let's go to the next image. Last year, she was like this. You find the difference? Of course, this nodule is a metastatic nodule. Look at last year's normal right hilum. What's the difference? First, size is increased. Denser than before, whiter than last year. And the margin is irregular. Anatomic structure, pulmonary artery is not clear. And how about the upper mediastinal border? Different than before? Yes. Let's confirm through the CT. Axial contrast enhanced chest CT. Bronchus intermedius. Large right hilar mass, conglomerated lymph node, and actually right paratracheal area is also the lymph node enlargement. Right hilar lung cancer. Left side is okay. What do we see with this film? Let's presume left side is okay. What do we see? Very large increased opacity. How about the pulmonary artery, descending pulmonary artery? Is that okay? Yes, it looks okay. Preserved shadow, margin, and anatomy. What about the airway? It looks okay. Okay. This image has a couple of signs. Hilum overlay sign and silhouette sign. Yes. Hilum looks okay. Although we see denser, larger mesh-like density over the hilar area, but we see the normal hilar structure through the mesh. Let's see the results. Long window setting of axial chest CT. This is the results. Right upper lobe anterior segmental 4 cm lung cancer, not overlapped with hilum, separated with hilum. That's hilum overlay sign and silhouette sign, not hilar pathology. This is the third case. What do we see? I'll be silent. You examine the frontal radiograph and imagine what is the true results. Please define the normal hilar structures. Left hilum is okay. Right hilum shows blah blah blah. Let's check up the CT image. This young man's CT axial image shows the cavitary tuberculosis and twin-bud patterns in the right lower lobe superior segment attached with hilar structure descending pulmonary artery. That's why we see this increased hilar density, unclear margin of descending pulmonary artery. In bilateral hilar enlargement, we see first lymphadenopathy of sarcoidosis or lymph node metastasis. Second, vascular dilatation of pulmonary arteries such as LR shunt of ASD or BSD and the pulmonary vein of left ventricular failure. In unilateral hilar enlargement, we see first neoplasm, most importantly neoplasm, lung cancer, second pericardial defect, third pulmonary embolism, Benjamin Felsen. This case is bilateral hilar enlargement due to lymphadenopathy, sarcoidosis. What do we see? Bilateral hilar enlargement. True hilar enlargement because hilar structures are not preserved. Normal structure, normal anatomies are gone. Lymph node enlargement. This is also lymph node enlargement due to higher density. This is sarcoidosis of bilateral hilar lymph node enlargement. Bilateral hilar enlargement due to enlarged central pulmonary artery, left-right shunt from the atrial septal defect. What about these hilar structures? You can confirm that these structures are enlarged proximal central pulmonary arteries. Preserved airway. This is the last slide of hilar pathology. What do we see? Normal, somewhat looking normal, or somewhat strange. Let's presume the right side hilum is normal. What's wrong with the left side? I'll keep silent. Non-contrast axial CT image at the hilum level. What do we see? Normal right pulmonary artery, normal left pulmonary artery. Nothing should be here. If something's here, it's wrong. This is small cell lung cancer. Small cell lung cancer at the left hilum. That's why this left hilum is dense, irregular margin, no demarcation of normal pulmonary vessel, and actually this linear density is lymphangitic obstruction due to tumor. Let's see again this film. If we meet this film again, what will do describe about this image? Normal or left hilar small cell lung cancer? I don't know. I'm afraid. What will I do? I think hilar pathology on the chest radiograph is one of the most important and toughest spots in chest radiology. How do you feel now when you see this image about hilar lesion? Surprised? Become dreadful? Or a little bit humble? More confident about the hilar pathology? More comfortable than before? Because hilar pathology often masquerades as normal, it is sometimes overlooked and sometimes undetected. The essence of the importance of hilum is the potential to miss the hilar pathology, especially the malignancy. If you feel a little more comfortable about hilar lesion after this session, you are in the middle of a mountain climb called a chest radiograph. Thank you very much, Dr. Y. This is the answer for the last quiz. Are you correct? And this is stomach with airfluid level, food. There is no stomach visualized here. Quiz for the next session. What's wrong with this healthy baby? Thank you very much. See you next time. Bye-bye. Like, subscribe will be a big support to me. Thank you very much.